Atherosclerotic cardiovascular disease is the commonest cause of mortality in Indian adults, accounting for about 35% of all deaths occurring in adults. Atherosclerotic cardiovascular disease has progressed in last 25 years in this country in exponential speed. The latest data released by the Registrar General of India shows that this continues to be the number one killer of Indians. There are multiple reasons why this is there, multiple risk factors. The commonest of these is dyslipidemias or abnormal lipid levels. There are other risk factors like hypertension, diabetes, smoking, obesity, genetic factors, and psychosocial factors. However, dyslipidemia probably accounts for 65% of all atherosclerotic cardiovascular disease in India, as has been shown by Interheart study, which was a multi-country study involving 52 countries studying the first incident of myocardial infarction. Dyslipidemia in Indian population is common. A recent study by Indian Council of Medical Research has shown that 3/4 of Indians suffer from abnormal lipid levels or dyslipidemia. And there is no urban or rural gradient. And that the males and females have probably equal proportion of dyslipidemia. Because of this significant prevalence of dyslipidemia, atherosclerotic cardiovascular disease is high amongst Indians. When you compare the data from the Western world, we Indians suffer from atherosclerotic cardiovascular disease probably 2 to 3 times more commonly. Even people who have migrated from India to United Kingdom or United States suffer from atherosclerotic cardiovascular disease at least twice more often than the native population. So obviously dyslipidemia is an important issue and we need to address it very, very seriously. There have been good attempts made first to define dyslipidemia amongst Indians, then to categorize it, find out the guidelines of management. Lipid Association of India has done tremendous job in this regard. Lipid Association of India was formulated in early 2014. It held several meetings across the country in almost 18 cities involving 153 specialists of all specialties like internal medicine, endocrinology, neurology, cardiology, vascular surgery, and so on and so forth, to get those experts together to hammer out the guidelines for management of dyslipidemia. It had been a humongous effort with multiple meetings throughout 2014 and 2015. And we are pleased to say that the Lipid Association of India has given guidelines which are relevant to India, which probably would prevent atherosclerotic cardiovascular disease significantly if followed. Largely, the guidelines address the issue of dyslipidemia with the non-drug approach, which is lifestyle modification, and also with drugs. The core of that remains statins. However, before we come to that management part, we need to understand that since lipids or dyslipidemia is more toxic to vasculature of Indians, the guidelines or the thresholds or the targets have to be lower for Indians. Indians also have different or peculiar type of dyslipidemias characterized by low HDL and high triglycerides. Both of these are actually not risk factors but risk markers indicating high propensity of Indians to atherosclerotic cardiovascular disease. Keeping that in mind, the guidelines, the experts met, discussed this issue threadbare, and found that although addressing HDL or triglycerides is by drugs is not which is going to give us dividends, and that still we have to address LDL, cholesterol, which is the bad cholesterol, which becomes more toxic, more poisonous in Indians in presence of low HDL and in high triglyceride, also in presence of diabetes or impaired glucose tolerance, in presence of smoking and visceral obesity. And that the target has to be LDL, which has to be aggressively lowered both for primary prevention as well as for secondary prevention. So the guidelines have gone ahead and suggested that compared to the Western population, our thresholds should be about 30% lower. Our target should be at least 30% lower. The targets for LDL cholesterol for very high risk individuals who have already atherosclerotic cardiovascular disease should be below 50 milligram per deciliter of LDL cholesterol. Those who are at high risk, like diabetics or those who have moderate kidney disease or those who have multiple risk factors, there the target has been suggested less than 70 milligram per deciliter for LDL cholesterol. And for everybody else with no or minimal risk, the target has been suggested that everybody should try to achieve an LDL below 100 milligram per deciliter. There are also targets for non-HDL cholesterol suggested by the Lipid Association of India, and those are essentially for all these 30 categories plus 30 milligram compared to LDL. So if the LDL was 50, non-HDL is 80 milligram. If the LDL target was 100 milligram, the non-HDL target is 130 milligram. The guidelines or recommendations or the consensus statement also discusses this issue that although lifestyle modification is extremely important, diet is important, losing weight is important, stopping smoking is important, meditation, yoga, etc. are extremely important, but it's far more important than when people are defined with very high risk or high risk that they should be on drug therapy. And a major component of drug therapy is statins, the drugs like atorvastatin, rosuvastatin, and of course to some extent pitavastatin and simvastatin. It has been suggested that very high risk individuals and high risk individuals should be given high intensity statin therapy. The high intensity statin therapy essentially means use a atorvastatin 40 to 80 milligram per day or use a rosuvastatin 20 to 40 milligram per day. For moderate intensity therapy, it is atorvastatin 10 to 20 milligram per day or 5 to 10 milligram of rosuvastatin or 2 to 4 milligram of pitavastatin or 20 to 40 milligram of simvastatin. If despite statin therapy prescribed in right doses and going up to the maximal dose, individuals continue to have LDL levels which are above the threshold, above the target, it has been suggested that non-statin drugs should be used, and non-statin drugs which have been suggested are essentially drugs like ezetimibe, which of course has been approved after statin as number 2 drug. There are other drugs like bile acid resins and fenofibrates which can be used. The point remains that we have to address the issue of high LDL aggressively. It has also been suggested that those people who have very high risk are not responding to statins or statin intolerant or despite multiple therapies continue to be above threshold or above target. The newer molecules which are called PCSK9 inhibitors, which are essentially monoclonal antibodies against LDL receptors, should be used. These are intravenous agents yet to be marketed in India, yet to be marketed in the world, but a lot of research has been done and these molecules have been found to be useful in lowering the LDL by as much as 60%, and hence a large majority of individuals will come below target once we start using PCSK9 inhibitors. Still the point remains that we need to increase awareness about dyslipidemia in the community. We need to explain to everybody that dyslipidemia accounts for 2/3 of atherosclerotic cardiovascular disease. And we also have to say that the intensive statin therapy is the only way to go forward in individuals who are very high risk or high risk, along with lifestyle modification. Having said that, myths about statin therapy need to be busted. Actually, the drugs are extremely safe. Very few adverse effects, very little chance of developing new onset diabetes or muscle pains or intolerance, and hence unnecessary phobia about statins should be discouraged. Besides, their other drugs are also reasonably safe and they should be used in the doses prescribed. So, in short, dyslipidemia is the major risk factor for atherosclerotic cardiovascular disease in whole of the world, more so in Indians, as inter-heart data suggests that if in the world the population attributable risk of myocardial infarction is 50% as a result of dyslipidemias, in South Asians like Indians, it is 65%. So it is important, we need to be more aggressive, the targets have to be lower. Fortunately, most statins in this country are generic. We should be using them aggressively. We should promote its use in all those conditions where these are required. Even individuals who have one or more risk factors, once they are above the age of 55 years, we should try to give moderate intensive therapy so that the risk of atherosclerotic cardiovascular disease, which is killing nearly 55%, nearly 60% of people below the age of 55 years, can be avoided. Thank you very much.